Hi, today we're going to talk about MR.
So one thing that I really didn't fully understand as a new grad nurse and that I came to appreciate a lot more in my training was understanding how patients with mitral valve regurgitation were so different than other types of heart disease patients, and how all of these different etiologies of heart failure just had such different disease processes and how it affected all of our patients so differently.
And what choices are you going to make as the nurse? How are you going to treat medication choices, fluid resuscitation, all of these things, especially fluid resuscitation, which we're going to get into. So yeah, how do you manage mitral regurgitation? And as we dive into it, my name's Anna.
My name's Chrissy.
And we're the co-founders of Confident Care Academy, which is the comprehensive online resource for new critical care nurses, where we have a membership and ongoing education for critical care nurses like you. But yeah, mitral regurgitation.
Yeah, so let's get into it. So, a little background on Anna and I. I'm a nurse anesthetist. Anna is a future nurse anesthetist. She's in school right now. But we used to work in CVICUs, cardiovascular units, and we worked with fresh post-op cardiac surgery patients.
The management of post-op cardiac surgery patients is so much fun, and this is what we're teaching in the membership right now. So We're talking about management of cardiac patients, and mitral regurgitation, it deserves its own video. So
it really does.
What is mitral regurgitation?
So, mitral valve regurgitation, any type of regurgitation, basically means backward flow. You could, if we want to get gross, you think about like when you regurgitate something, your food is coming up, right? Things are going against the normal flow. They're going backwards through a valve, or in this case, a sphincter. But in the heart, mitral valve regurgitation means that actually, before we get into that, we should briefly say what a valve is.
Oh, what is a valve?
Let's back this bad boy right up.
We're gonna back it up.
We're gonna back it up. So isn't it funny like how far you come when you like you go back and you look and you're like, wow, I know a lot. Okay, we gotta back it up a little bit. So what's a valve? A valve is a door that opens and closes. That's it. It opens in one direction and then it closes. That's it. One-way valve. And that exists in the body. There's valves in your heart that allow blood to flow forward, and they close so it doesn't flow backwards.
Valves in your blood vessels.
And there's valves in your veins.
Yep.
Not the arteries, the veins.
Veins.
And they bring, blood forward, back towards the heart against the flow of gravity and prevent it from flowing backwards, right?
Yeah.
So, back to valves. So, your mitral valve is in the left side of the heart. It's between the left atrium, the top of the heart, and the left ventricle, the bottom of the heart. Blood comes into the left atrium from the lung.
Full of oxygen, and it goes from the left atrium into the left ventricle before it gets pumped into the aorta to be delivered to the rest of the body.
The mitral valve separates the left atrium and the left ventricle. And during diastole, when the left ventricle is filling, it's going to open up. The door is going to open and allow blood to leave the left atria and go into the left ventricle. Then when it's time to pump the blood to the body, the mitral valve closes so that when the left ventricle squeezes, it doesn't go backwards into your lungs, it all goes forward into the body, out into the aorta, right?
The heart is all about forward flow.
All about it.
This is the main thing as a new grad that is going to help you, or as a new critical care nurse, is to understand what steps along the way happen to make forward flow happen. And then if there's something that stops forward flow, how do you fix it? That is exactly what the heart is about. That's what understanding heart failure is about, and that's what understanding mitral valve regurgitation is about.
Exactly.
So, also, the papillary muscles, are going.
We love them. They're so important.
Very interesting, and I'm excited in the heart failure month to talk about pap tears, because that was very poorly understood by me as a new grad.
All right, so regurgitation, we already said that's backwards flow, right?
Yes.
So there's different causes for why a mitral valve might regurgitate. Sometimes, people might just have like a little mitral valve prolapse, and it's just a very mild prolapse. I don't know another word for prolapse.
If there's
floppiness, a little mild floppiness in the valve, let's say, where it's not totally coapting, sealing and closing together, coaptation, right? So like that might be something that people just have, like just they're born with, or it just kind of develops over time. There is, papillary muscle rupture. Those little papillary muscles
is what helps the valve to open and close. So it's what is attached to the little leaflets. So if the papillary muscle is torn, then the leaflets aren't going to open and close correctly.
Right, and then you can have like pretty much wide open MR is what we call it, which is when like you're now having like basically a leaflet that's flailing backwards every time the ventricle squeezes. And think about it, right? Like if you have something going like this, have you ever like squeezed like a water balloon, right? And then like some of the water goes up and some of it goes down.
Yeah.
If you had something hard blocking the top of your hand, all the water would go down. But if you don't have something blocking it anymore, the water would go in both directions,
Yep.
right? So that's basically what's happening. And there's other reasons too. Calcification over time, just as a natural part of aging,
Yeah.
vascular disease, lots of different causes. But at the end of the day, you know, the severity of how big the backwards flow is going to, you know, affect your patient significantly.
Very true.
How quickly the sequelae, the chain of events that comes next, like comes about. And it's going to really significantly affect how you manage your patient. So this is something that I think I really poorly understood as a nurse. And the biggest myth that we're going to bust today.
Oh man, okay, so we're doing commonly heard things on the unit and how we're gonna just some like myth busting. Okay, so you may have heard as a new ICU nurse that all valves need fluid. And now Chrissy needs CPR. So that is one of these blanket statement half-truths that you will often hear from other nurses teaching other nurses, because again, once again, people have the orientation cut short, and then people never really dive into the why and the patho behind what they're doing sometimes. And then this is one of these little sayings that gets perpetrated, and you might hear, you know, all valves need fluid, just like levo does squeeze, which is again kind of true, but not really the whole story. So why would mitral valve regurgitation be different from like aortic regurgitation, the treatment modality? If you think about it, it's a forward flow thing. So as we were taught in nursing school often that left-sided heart failure progresses to right-sided heart failure. Okay, why? Why? You have to back it up step by step by step. And if you have a regurgitating, so a floppy mitral valve,
Backward flow,
where you
right?
have backward flow, and
Well, where does the flow back up to first?
so if your mitral valve is in between your left atria and your left ventricle, if you've got backwash, where is that backwashing to?
First, the left atria, right?
Yes.
So what's the first thing that happens in the progression of this disease? So, you know, two things depending on the severity.
Right.
First of all, you've had a reduction in forward flow because some of it's flowing backwards. So less cardiac output, right? So that's like probably the first thing. You know, in a mild MR, you're not going to see a big difference, but in severe MR, your patient's going to probably present like cardiogenic shock. Like I'm talking wide open MR after like a PAP muscle rupture. But you know, so the spectrum can be anywhere in between. So okay, reduce cardiac output in theory, potentially.
Yep.
Second, backing up into left atria. What's going to happen to the atria over time? It's going to dilate. It's going to get bigger. It's going to stretch out. And when atrias dilate, when anything dilates in the in the heart, it's going to have like thinner, stretched out muscle. It's going to change the cardiac muscle cells themselves. Mm-hmm. So the way that they conduct like electrical impulses is actually going to change at the cellular level. And it's also going to like kind of deform the pathway of conductivity through the left atria. So like,
because the heart does multiple things. It's a muscle and it squeezes and it does forward flow, but it also conducts electricity. So when you're damaging these cardiac muscle cells, the myocytes, when you're damaging the heart, you're damaging not only its ability to contract, but also, in this case, its ability to do conduction.
Yeah, exactly. So, like just a really quick recap, you've learned in nursing school that where does how does the flow of electricity go through the heart, right? So the sinoatrial node, the SA node is like the pacemaker of the heart that sets the beat. And then what's going to happen is that the electrical impulse is going to get conducted down to the AV node, and it's going to go to the bundle heads, it's going to go through the bundle branches, and the Purkinje fibers, all the way through the left ventricle, right? And then sometimes we kind of gloss over and forget that there's internodal pathways making the atria depolarize also along the way. So, from that like right-sided SA node, the electrical conductivity has to kind of diffuse across the atria so that the atria contracts, right?
Which is what your P wave is the depolarization of the atria. As a new graduate, it's helpful to think about you squeeze tops, you squeeze bottoms. Like tops, bottoms. And then what causes the top bottom is the depolarization of the atria.
Exactly.
Which we're getting into in December. We're doing conductivity in December in the membership. So come join us.
Yeah. But let's back it back up to the left atria, right?
Yes.
So now we have a dilated left atria and we've jankied it up. We got a jankied up left atria. So what's one of the first things that you might see with a patient like this? Atrial fibrillation. We've jankied up the conduction system, guys. Just saying. All right.
So you're going to have, you might see AFib, which totally makes sense.
Probably, likely, very often. Then, what comes next? What dumps into the left atria, Anna?
you're coming with oxygenated blood from the lungs.
From the lungs. So the PA, the pulmonary arteries, pulmonary vein system, pulmonary veins are what like return the blood to the heart from the lungs. That being said, it's going to back up into the lungs. You can get literally like pulmonary arterial hypertension. Pulmonary artery pressures that are high are very bad because that puts a lot of strain on what comes before the PA.
The right heart.
The right heart, not specifically the right ventricle, right?
Yeah, the RV.
And the RV is naturally thinner and weaker than the LV because your entire life, it's never had to pump that hard. It's never been delivering blood to your whole body. It's always been delivering blood to just your lungs, like a low flow, low pressure system. So think about how like muscles develop naturally in the gym. When you go and lift weights, if you're lifting weights and working out all the time, you're gonna get pumped, you're gonna get swole, right?
Yeah.
So your LV, in theory, should be swole. But your RV has only been like just doing cardio, like, right? It's been like, I didn't mean to, no pun intended, guys. I was trying to make an analogy here. That was a bad one.
Your left ventricle's a bodybuilder, and your right ventricle's a cardio bunny.
Does some power walking. I don't know what it's been doing, but it's not been doing heavy lifting. Yeah. So now you're making it do heavy lifting all of a sudden. That's a very bad thing. So once your RV starts to fail, what's that receiving blood from? Your right atrium, or is that receiving blood from your whole freaking body?
So then you get into the portal hypertension, you get into, in very severe cases, liver failure. Your body is all connected.
Failures, everything else, it's all bad.
It's all very, very bad. So back to mitral valve regurgitation. If this is a patient where you're going to be seeing left atrial remodeling and then potentially backing fluid up into the lungs, are you going to drown that patient with fluid? Are you going to give them a lot of fluid? No.
Negativo.
You do not want to give mitral valve replacement or regurgitation patients a lot of fluid because they're already likely to be having some backflow and to have, they're likely
they already have some RV failure usually.
Yeah, they're already holding fluid in the lungs, they're having some RV failure, and if you don't have forward flow, then you're looking at your right-sided heart failure, you're looking at increased transfer pneumonia, you're looking at decreased forward flow altogether.
Decreased forward flow, yeah. And the right heart failure is like, obviously a very bad thing. Yeah. So thinking about your post-op cardiac surgery patient, first and foremost, like these patients come up and a couple things happen that are a little bit misleading. A lot of times we listen to the echo report and we hear the EF, the ejection fraction, the amount of blood that gets squeezed from the left ventricle. You hear that they usually have like either a normal or close to normal EF. So normally that's like how we take the shortcut in our brains of thinking like, how bad is our heart failure?
Right.
So you're like, EF, like 45%, you're like, that's not so bad. Like a little decrease, like it's fine, it's like moderately down, that's not so bad, right? But then you realize when you close your eyes and think about it, that is in the context of half the blood flowing backwards or a percentage of the blood flowing backwards, right?
Yeah.
So the left ventricle is able to squeeze out like a decent percentage of blood, but not to the body, right? It's not because the LV is doing such a great job. It's because a lot of it's just getting backwashed, regurgitated back. So we don't really know how well the LV is actually pumping. So what happens is after cardiac surgery, when they either replace or repair the valve, that's when you get to discover how good the LV is actually working. Because now you've closed the door, it's not allowed to be lazy anymore, the blood's not allowed to flow backwards anymore, and the LV has to wake up and do the work, and these patients typically have a big hit in their ejection fraction afterwards. Usually now your patient who started with the EF of 45 now has an EF of 30. I used to think as a nurse that, wow, they've had a really decreased ejection fraction. It must be due to myocardial stunning. It must be due to inflammations. Yeah, those are factors, but the reality is the LV's probably been that crappy all along in this patient population. That's not true for every type of cardiac surgery patient.
And so as you progress, as you continue to learn, you're going to see all the pieces of the puzzle are coming together, and the ejection fraction, how much of the blood is moving forward. You want typically greater than 55%?
Yeah. 55 to 65 is normal.
Yeah, greater than an EF greater than 55 is normal. 55% is normal. So then correct. So then if you have a patient who has less than that, and then we're now fixing the valve, so instead of counting both backwash and forward wash as just working, now you see, oh wait, actually we do have some pretty profound heart failure in this patient population. And then what's the next step? Are you going to give a ton of fluids to a patient who has pretty profound right-sided heart failure? No.
Yeah, so that's the thing, right? These patients usually have like mild to moderate RV dysfunction before surgery, or maybe even severe, depending on how long they've had the MR and how severe it's been. But now once we've undergone cardiac surgery, usually the RV takes a hit in almost all cardiac surgeries anyway. It will recover over time, especially if we're really good at optimizing our patients. But it's going to take a hit during surgery. So now you're taking a mild to moderately down RV, and maybe it's becoming moderate to severe, for example. So you want to be really on top of, being very, very cautious with your fluid administration. If your patient, you might be more quick to replace volume with blood products in this patient than maybe some other patients, because you can give less crystalloid and get more bang for your buck.
Well, LR doesn't carry oxygen.
LR doesn't carry oxygen.
Yeah.
So instead of giving your patient, you're going to learn this in CRNA school, Anna, but the way that we're supposed to replace lost blood volume with crystalloid versus colloid versus blood.
Oh, I can't wait.
So good. But they say that for every, it's a 3-to-1 ratio of crystalloid to blood loss. So if you lose, say you lose a liter of blood, it would take 3 liters of crystalloid to resuscitate that volume back. Don't do that. That is a bad thing. Don't do that. I'm just easy math there, right?
Right.
Blood, it's a 1-to-1 ratio. So if you lose a liter of blood, you give back a liter of blood.
Yeah.
So think about, your post-op patient who's maybe had some blood loss, they have a weak RV, their LV's not as good as you thought it was, and now you're pumping them up with LR in order to make your blood pressure look better. First of all, don't do that. Just go up on the IV, just don't do that. Second of all, if you do need to give them product, you're probably gonna wanna give them blood, and if their hemoglobin's fine and they don't need more blood, maybe you're gonna give some FFP. That's probably gonna be your next best choice, because again, you could give it into 1-to-1 ratio, and also those patients usually need clotting factors after they've done bypass.
I'm so excited to talk about the bleeding and clotting lectures. That's going to be so fun.
Yeah. We get into those.
I think February.
February?
Yeah, it's a little bit later.
We got so many good things coming for you guys.
Oh, yes. So I think these are all really, really key considerations, because it's so much deeper than all valves need fluid. Because
all valves do not need fluid.
So if someone else says that when you become a preceptor in approximately 2 months,
tell them they're a liar.
You will not be saying that all valves need fluid.
They do not all need fluid.
Yeah.
And these are the patients where you're going to focus more on contractility agents. So getting to the pressors lectures, you're going to be favoring epinephrine and norepinephrine for these patients. You're also going to be really paying close attention to your SWAN numbers, your PA pressures, your CVP. This is a time when your CVP should actually be thought about, right? Because sometimes we don't use CVP as a way to give back fluid. We don't do that. That is not evidence-based, but it is a good indication of how your RV is doing.
Right.
On top of that, we are going to be really cautious with the PA pressures and just helping forward flow. So your patient might be on Flolan, for example, if they have any pulmonary hypertension. We want to keep the pulmonary hypertension down. We want to make it as easy for that RV to work as possible.
Other places, Velitri, inhaled nitrous oxide.
Yeah, Velitri and Flolan are the same.
They're the same. But again, brand names.
We're letting you guys know. There's
names.
6 names for Flolan. It's
Anyway.
Isoproterenol. I don't know. Velitri, Flolan, and not brand name.
Pulmonary?
Nitric oxide.
Inhaled nitric oxide.
Inhaled nitric oxide, and then, who knows, they could be on a bunch of other stuff too.
Milrinone to a certain extent, right?
I say Milrinone. Milrinone's possible. Yeah, that's another option.
Which, all of which we're going to talk about a lot more in the heart failure lectures, which is in December. So it seems like a lot, but really, as you are learning, really think about forward flow, draw it out, understand the anatomy, and see what is stopping forward flow at each level, and then think about what you're going to do to fix it.
Yeah, and think to yourself, does this patient really need more fluid? Do they need pressors? Do they need fluid? Okay, probably not fluid, pressors. Okay, what kind of pressor? Probably not phenylephrine, right? That's just going to increase our afterload, make it harder for the heart to pump out blood.
And go check out our video that is also up about the receptor sites. So we have a YouTube video that is up about alpha, beta, which medications you're going to choose, and the sympathetic and parasympathetic nervous system. So we're going to have that one linked right up here. You can go watch that one next. But yeah, choose wisely.
Choose wisely. Choose wisely and understand why you're doing everything you do. And that's really more of the story. So guys, if you like this stuff, first of all, comment below what you want to hear more. What questions do you have you heard this myth on your own unit? And if you want to get a deeper dive into all things heart failure, all things cardiac, join us in the New to ICU membership, all right? We're going to be talking way more about this stuff. We have exclusive videos every month. We have live Q&As and case studies. We have handouts. We have downloads. We have a discussion board. We have community support. So you guys are going to get everything you need to thrive in the ICU.
Thanks for joining us.
See you next time.